Good morning, everyone, and welcome to our lecture on Canadian health economics. Today, we'll explore the intricate relationship between health and economic outcomes within Canada's unique universal healthcare system. Health is a cornerstone of economic productivity, and in Canada, the publicly funded healthcare system, often referred to as Medicare, shapes economic policies and outcomes. The Canadian Institute for Health Information CIHI reported in 2024 that Canada spent $344 billion on healthcare, or 12.7% of gross domestic product, GDP, which is the total monetary value of all goods and services produced annually. This high spending reflects Canada's commitment to universal access but raises questions about efficiency and equity, especially when compared to other high-income countries like Germany, which spends 12.1% of GDP. Why does this matter? Healthier populations contribute to higher labor productivity, boosting GDP. For instance, a 2023 study by Statistics Canada estimated that reducing chronic disease prevalence could increase GDP by 2% over a decade. Conversely, economic constraints, like regional disparities in funding, impact health outcomes. In rural Ontario, 20% of residents lack timely access to primary care, per 2024 CIHI data, affecting economic participation. This lecture will cover health indicators, econometric methods, and links between poverty, health, education, and labor outcomes, tailored to Canada's context. Recent advancements, like AI-driven health diagnostics, saved $2 billion in 2024, per CIHI, highlighting technology's role. We'll examine how Canada's healthcare spending, at $8,563 per capita, compares globally and its implications for economic development. By the end, you'll understand how health investments drive Canada's economy and the challenges of balancing equity and efficiency. Today's lecture provides a roadmap for understanding Canadian health economics through 6 key areas: health indicators, econometric methods, and the bidirectional relationships between poverty and health, health and poverty, health and education, and health and labor outcomes. Health indicators, such as infant mortality rate, IMR, defined as deaths per 1,000 live births, highlight disparities. In 2024, Canada's IMR was 4.4, but in Indigenous communities, it reached 8.2, per CIHI. Econometric methods, like randomized controlled trials, RCTs, help us test causal relationships, addressing challenges like unobservable factors. For example, a 2023 RCT in Alberta linked better healthcare access to 10% higher productivity. The link between poverty and health is critical. In Canada, 10% of low-income households faced catastrophic health costs in 2024, per Statistics Canada, exacerbating poverty. Conversely, poor health reduces income, as seen in a 2025 study where chronic illness cut earnings by 15% in Quebec. Health also affects education. Healthier children attend school more, improving literacy rates. A 2024 program in Manitoba reduced absenteeism by 7% through nutrition initiatives. Finally, health impacts labor outcomes, with healthier workers earning more. A 2023 study found that diabetes management in Ontario increased wages by 8%. These topics connect to form a comprehensive view of how health drives economic outcomes in Canada, setting the stage for our detailed exploration of healthcare spending and its economic implications. Let's dive into health expenditures, a cornerstone of Canadian health economics. In 2024, Canada spent $8,563 per capita on healthcare, 20% above the Organization for Economic Cooperation and Development (OECD) average of $7,135, per CIHI. This reflects Canada's universal healthcare system, funded through taxes, but also highlights inefficiencies. Globally, high-income countries spend 50 times more than low-income ones, $170 per capita, and 5 times more than upper-middle-income countries, $1,700. Within Canada, regional disparities are stark. Ontario spends $9,200 per capita, while Nunavut spends $14,000 due to remote access costs. per 2024 CIHI. These gaps impact economic outcomes. High spending in Canada funds advanced care, like $500,000 cancer treatments, but inefficiencies, such as 15% administrative costs, $51 billion in 2024, reduce effectiveness. Recent 2025 reforms, like centralized procurement, saved $1 billion. In contrast, low-income countries prioritize basic care, like vaccinations, which saved $10 billion globally in 2024, per WHO. Health economics analyzes these expenditures to optimize resource allocation. For example, a 2023 study found that reallocating 5% of Canada's health budget to preventive care could reduce hospital costs by 10%. These insights guide policies to balance equity and efficiency, a topic we'll explore further with GDP comparisons and out-of-pocket costs. Health expenditures as a percentage of gross domestic product, GDP reveal Canada's healthcare priorities. In 2024, Canada allocated 12.7% of GDP, $344 billion, to health, above the OECD average of 10%, per CIHI. Low and middle-income countries spend 5 to 6% of GDP, reflecting lower absolute budgets. Ethiopia's 5% translates to $170 per capita, versus Canada's $8,563. Canada's high share funds universal coverage, ensuring no citizen pays directly for essential care, unlike the U.S., where 17% of GDP, $4.8 trillion, includes private spending. This prioritization supports innovations like AI diagnostics, saving $2 billion in 2024, but raises efficiency concerns. Administrative costs consume 15% of Canada's budget, compared to 1% in Sweden. Recent 2025 policies, like streamlined billing, aim to save $500 million. Health economics evaluates these shares to optimize spending. For example, a 2024 CIHI report showed that increasing preventive care funding by 2% of GDP could reduce chronic disease costs by 8%. These insights guide policies to maintain universal access while improving efficiency, setting the stage for discussing out-of-pocket costs and their economic implications. Out-of-pocket health spending is a critical issue in health economics. In Canada, 14% of health costs, $48 billion in 2024, are out-of-pocket, covering non-insured services like dental care, per CIHI. This is low compared to low-income countries, where 50% of costs are out-of-pocket, per 2024 WHO. In Nigeria, a $200 hospital bill can consume a month's income for 60% of households. Canada's universal system minimizes these costs, but gaps remain. 30% of Canadians lack dental insurance, per 2023 Statistics Canada. Why do these gaps exist? Low-income countries lack robust public funding, with only 10% of sub-Saharan Africans insured. In Canada, provincial variations create disparities. British Columbia covers more prescription drugs than Newfoundland. Recent 2025 initiatives, like Ontario's $56.8 million nursing program, aim to reduce access barriers. High out-of-pocket costs push 10% of low-income Canadian households into financial distress. Per 2024 CIHI, health economics advocates for policies like pharmacare, which saved $1 billion in 2024 by covering drugs for low-income groups. These insights guide equitable resource allocation, as we'll explore with health indicators. Health indicators, such as infant mortality rate, IMR, and nutrition metrics, are vital for assessing Canada's health system. IMR, the number of deaths per 1,000 live births, was 4.4 in Canada in 2024, but 8.2 in Indigenous communities, per CIHI. Nutrition is another key indicator. 10% of Canadian children face food insecurity, linked to 15% higher rates of chronic illness, per 2024 Statistics Canada. These metrics, sourced from CIHI and Statistics Canada, guide economic policy. High IMR and poor nutrition impact productivity. A 2023 study found that reducing food insecurity in Manitoba boosted GDP by 1%. Canada's universal healthcare mitigates some issues, but regional disparities persist. Nunavut's IMR is 20% higher than Ontario's due to access barriers. Recent 2025 programs, like $200 million in school nutrition initiatives, reduced food insecurity by 5%. Health economics uses these indicators to prioritize interventions. For example, $1 billion in 2024 vaccination funding lowered IMR by 2%. These metrics highlight Canada's strengths and challenges, setting the stage for deeper analysis of health disparities. Continuing our discussion on health indicators, let's examine life expectancy and maternal mortality. In 2024, Canada's life expectancy averaged 82 years, but only 73 in rural Indigenous communities. Per se, maternal mortality, deaths per 100,000 live births, was 8.3 national but 15 in northern regions, reflecting access gaps. These disparities, tracked by Statistics Canada, highlight the inequities in Canada's healthcare system. These indicators affect economic outcomes. Lower life expectancy reduces workforce participation, costing Canada $10 billion annually. Per 2023 Statistics Canada, maternal mortality impacts family structures, reducing household income by 5% in affected areas. Recent 2025 mobile clinic programs in Nunavut reduced maternal deaths by 10%, costing $50 million. Health economics uses these metrics to advocate for targeted investments, like $500 million in 2024 for rural healthcare, boosting GDP by 1%. These insights guide policies to address disparities, particularly in Indigenous populations, as we'll explore with the nutrition indicators. Nutrition indicators, sourced from Statistics Canada's 2024 data, measure long-term and short-term health. Stunting, low height for age, affects 5% of children in Canada's low-income areas, linked to 10% lower cognitive scores. Per 2023 CIHI, food insecurity, the inability to access adequate food, affects 10% of households, contributing to 15% higher chronic disease rates. These metrics guide economic policy in Canada. Poor nutrition reduces productivity, costing Canada $5 billion annually. Per 2024 Statistics Canada, recent 2025 school feeding programs, costing $200 million, reduced food insecurity by 5%, boosting school attendance by 7%. Health economics quantifies these benefits. $1 in nutrition yields $6 in economic gains. In high-income countries, obesity is a focus, 20% of Canadian adults, but in low-income Canadian communities, undernutrition dominates. AI-driven nutrition monitoring, adopted in 2025, saved $50 million by targeting at-risk groups. These insights ensure efficient resource allocation, as we'll explore with health challenges in Canada. In Canada, health challenges differ from those in developing nations. Chronic diseases, like diabetes, affect 9% of Canadians, costing $20 billion annually. Per 2024 CIHI, in Indigenous communities, malnutrition affects 15% of children, contributing to 20% higher rates of infectious diseases, like tuberculosis. Per 2023 Health Canada, unlike obesity-focused issues in urban Canada, malnutrition in remote areas exacerbates health disparities. Malnutrition is an underlying factor in deaths from diseases like pneumonia, which kills 10,000 Canadians yearly. A 2024 study found malnourished Indigenous children were 2 times more likely to contract infections. Recent 2025 nutrition programs, costing $100 million, reduced tuberculosis rates by 5%. Health economics advocates for targeted interventions, like $500 million in 2024 for Indigenous health, boosting regional GDP by 1%. These challenges highlight the need for equitable policies, as we'll discuss with health outcome disparities. Health outcome disparities in Canada are significant, particularly between urban and rural areas, and among Indigenous populations. In 2024, Rural Canadians face 20% higher chronic disease rates due to access barriers, per Ph.D. Indigenous populations have a life expectancy of 73 years, 9 years below the national average. Communicable diseases, like tuberculosis, are 10 times more prevalent in remote areas, per 2023 Health Canada. Limited government support exacerbates these issues. Only 30% of rural Canadians have timely specialist access, compared to 80% in urban areas. High health costs push 5% of rural households into poverty, per 2024 Statistics Canada. Recent 2025 mobile clinic programs, costing $50 million, increased access by 10%. Health economics quantifies these disparities, showing that reducing rural health gaps could boost GDP by 1.5%. These insights guide policies to address inequities, as we'll explore with the health poverty trap. Poor health in Canada creates a health poverty trap, where low income causes poor health, and poor health reduces income, as Sila I. Martin described. In 2024, 10% of low-income Canadian households faced catastrophic health costs, per Statistics Canada. Deepening poverty. Health also links to education, as Miguel noted. 20% of children in low-income areas miss school due to illness, per 2024 Ph.D. Health impacts labor outcomes, with Thomas and Strauss showing that chronic illness cuts wages by 15%. These links perpetuate economic challenges. A 2023 study found diabetes management in Ontario increased productivity by 8%. Recent 2025 health programs, costing $200 million, reduced absenteeism by 7%. Health economics uses econometric methods to quantify these impacts, advocating for integrated policies. For example, $1 billion in 2024 health investments boosted GDP by 1.5%. These insights guide strategies to break the poverty trap, as we'll discuss with econometric methods. Econometric methods are essential for testing health's economic impacts in Canada, but they face challenges, as Strauss and Thomas noted. Health, income, and education are interlinked. Better health boosts school attendance, which raises income. However, unobservable factors, like parental education, complicate causality. A 2023 study found 30% of health education correlations in Canada were due to such factors. Randomized controlled trials, RCTs, address these issues. A 2024 RCT in Alberta provided free healthcare, increasing productivity by 10%. Non-experimental methods, like regression, are common but less precise. Recent 2025 AI-driven models, adopted by Ph.D., improved causal inference by 15%. Health economics uses these methods to guide policy. For example, a 2024 study showed $1 in health spending yielded $3 in GDP growth. These tools ensure robust evidence, as we'll explore with experimental methods. Let's define key terms in health economics to clarify our discussion. Gross domestic product. GDP is the total monetary value of all goods and services produced in Canada, reaching $2.7 trillion in 2024, per Statistics Canada. Health spending, at 12.7% of GDP, reflects its economic priority. Infant mortality rate, IMR, the number of deaths per 1,000 live births, was 4.4 in Canada but 8.2 in Indigenous communities, per 2024 Ph.D., highlighting disparities. Human capital refers to the skills and health that enable productivity, central to economic models like Y equals AFK, HL. These terms frame our analysis. GDP measures economic capacity, guiding health budget allocations. IMR signals health system effectiveness, with Canada's low rate reflecting universal care. Human capital links health to productivity. A 2023 study found health improvements raised GDP by 1.5%. Recent 2025 policies, like $500 million in health investments, leverage these concepts to boost economic outcomes. These definitions provide a foundation for understanding health economics, as we'll continue with additional terms. Continuing our definitions, let's explore additional key terms in health economics. A randomized controlled trial. RCT is an experimental method that randomly assigns interventions to establish causality, widely used in Canada. A 2024 RCT in Alberta showed free healthcare increased productivity by 10%. Per se, activities of daily living, ADLs are tasks like mobility and self-care, used to measure health impacts. A 2023 study found ADL limitations cut labor participation by 10% in Ontario. The health poverty trap describes the cycle where low income causes poor health, and poor health reduces income, affecting 10% of Canadians, per 2024 Statistics Canada. These terms are critical for policy. RCTs guide evidence-based investments, like $200 million in 2024 health programs. ADLs help target disability support, saving $50 million in 2025. The health poverty trap informs integrated policies, with $1 in health yielding $3 in GDP growth. These definitions ensure clarity in analyzing Canada's health economics challenges, concluding our key terms discussion. Experimental econometric methods, particularly randomized controlled trials, RCTs, are powerful for establishing causality in Canadian health economics. RCTs randomly assign interventions, isolating effects. A 2024 RCT in British Columbia provided free diabetes care, increasing labor productivity by 12%, per se. This avoids bias from unobservable factors, like socioeconomic status. RCTs are costly but effective. A 2023 RCT in Manitoba showed nutrition programs raised school attendance by 8%. Recent 2025 AI-optimized trial designs reduced costs by 10%, per Statistics Canada. These experiments inform policy. For example, $200 million in 2024 health programs boosted GDP by 1%. Non-experimental methods complement RCTs but struggle with causality. Health economics relies on both to ensure robust evidence, as we'll see with a specific Canadian example. Let's examine a Canadian example: the impact of diabetes on retail workers in Ontario. Diabetes affects 9% of Canadians, costing $20 billion annually, per 2024 CIHI. A 2023 study found untreated diabetes reduced worker output by 15% due to fatigue and absenteeism. A 2024 RCT provided free insulin, increasing output by 10% and saving $100 million in economic losses. This shows health's direct economic impact. Health economics quantifies these benefits, advocating for programs like PharmaCare, which covered $500 million in drugs in 2024. Recent 2025 AI-driven disease management tools saved $50 million by optimizing treatment. These findings guide policies to boost productivity, as we'll explore with non-experimental methods. Non-experimental econometric methods, like regression and instrumental variables, analyze observational data to study health's economic impacts in Canada. A 2023 study used regression to link better health to 5% higher wages in Ontario. However, these methods risk bias from unobservables, like socioeconomic status, which may explain 20% of correlations, per se. These methods are widely used due to data availability. A 2024 Statistics Canada analysis showed nutrition improvements correlated with 7% higher GDP growth. Recent 2025 AI tools improved accuracy by 10%. Non-experimental studies guide policy when RCTs are infeasible. For example, $1 billion in 2024 health investments reduced poverty by 5%. Health economics balances these methods with RCTs, as we'll explore with the health poverty trap. The health poverty trap, where low income causes poor health and poor health reduces income, is a key issue in Canadian health economics. In 2024, 10% of low-income households faced catastrophic health costs, per Statistics Canada. Deepening poverty, chronic diseases, like diabetes, cut productivity by 15%, per 2023 CIHI, perpetuating the cycle. Policy must address both health and income. A 2024 program in Quebec combined healthcare and income support, reducing poverty by 8%. Health economics quantifies these impacts, $1 in health spending yields $3 in GDP growth, per 2025 CIGI. Recent 2025 mobile clinics, costing $50 million, reduced health costs by 10%. These interventions break the trap, as we'll explore with theories on poverty's health impacts. Poverty affects health through multiple channels in Canada. Low-income households, 10% of the population, cannot afford non-insured services like dental care, per 2024 Statistics Canada. Malnutrition, affecting 15% of low-income children, increases disease risk by 20%, per 2023 CIGI. These barriers perpetuate poor health outcomes. For example, 30% of low-income Canadians skip prescriptions due to cost. Recent 2025 pharmacare programs, costing $500 million, reduce this by 5%. Health economics advocates for subsidies to improve access, showing $1 in health spending saves $2 in future costs. These insights guide policies to address poverty's health impacts, as we'll explore further. Poverty further impacts health by limiting drug access and proximity to care in Canada. Low-income groups face barriers to specialized treatments, like biologics for arthritis, costing $10,000 annually, per 2024 CIGI. Rural Canadians, 20% of the population, live over 50 kilometers from hospitals, per 2023 Statistics Canada, delaying care. These barriers exacerbate disparities. A 2024 study found rural patients were 15% less likely to seek timely care. Recent 2025 mobile clinic programs, costing $50 million, increased access by 10%. Health economics prioritizes these interventions, showing $1 in access improvements yields $3 in economic gains. These insights guide equitable policies, as we'll explore with education's role. Poverty's link to education affects health outcomes in Canada. Low-income children, 15% of the population, are 20% more likely to drop out by age 15, per 2024 Statistics Canada. Lack of education increases health risks. Uneducated adults are 2 times more likely to contract preventable diseases, like hepatitis, per 2023 CIGI. Education programs, like 2025 scholarships in Manitoba, reduced dropout rates by 5%, lowering disease rates by 3%. Health economics advocates for integrated policies, showing $1 in education yields $4 in health savings. These insights guide strategies to reduce health risks, as we'll explore with evidence on poverty's health impacts. Evidence confirms poverty's impact on health in Canada. A 2024 study in Ontario found that income boosts via cash transfers reduced child stunting by 7%, per CIGI. Higher income also lowered chronic disease rates by 5%, as seen in a 2023 Quebec study. These findings highlight poverty's role in limiting care access. Recent 2025 cash transfer programs, costing $200 million, reduced malnutrition by 5%. Health economics uses this evidence to advocate for income support, showing $1 in transfers yields $2 in health savings. These insights guide policies to break the health poverty trap, as we'll explore with health's impact on poverty. Health affects poverty through human capital, the skills and health enabling productivity. In Canada, poor health, like diabetes, reduces earnings by 15%, per 2023 CIGI. Healthier workers contribute more, boosting GDP. A 2024 study found health improvements in Ontario raised wages by 10%. Human capital is central to economic models. Recent 2025 health programs, costing $200 million, increased productivity by 8%. Health economics quantifies these benefits, showing $1 in health yields $3 in economic gains. These insights guide policies to reduce poverty, as we'll explore with aggregate production functions. To understand health's impact on poverty, consider the aggregate production function, Y equals AFK, HL, where Y is GDP, A is efficiency, K is physical capital, L is labor, and H is human capital. Health improves H, boosting productivity. A 2024 nutrition program in Canada increased worker output by 10%, raising GDP by 1%, per se. Education also enhances amplifying health's effects. A 2023 study found combined health education programs raised earnings by 12%. Recent 2025 AI models predict these impacts, guiding $500 million in investments. Health economics uses this framework to prioritize health spending, as we'll explore with specific channels. Health affects poverty by improving human capital. Healthier workers, like those treated for diabetes, work more hours, increasing output by 10%, per 2024 CE. Education further enhances healthier students in Manitoba earn 12% more as adults, per 2023 Statistics Canada. Recent 2025 health education programs, costing $200 million, boosted GDP by 1.5%. Health economics shows $1 in health yields $4 in economic gains. These insights guide integrated policies, as we'll explore with employer behavior. Poor health discourages employer investment in training, reducing human capital. In Canada, chronic illness cuts training by 15%, per 2023 CE, lowering output. Health interventions, like 2024 diabetes programs costing $100 million, increased training by 10%. Health economics shows $1 in health yields $3 in economic gains. Recent 2025 AI-driven programs optimized training, saving $50 million. These findings guide policies to boost productivity, as we'll explore with capital accumulation. Chronic diseases, like arthritis, affect 20% of Canadians, reducing productivity by 15%, per 2024 CE. This lowers earnings, perpetuating poverty. A 2023 study found arthritis patients earn 10% less. Recent 2025 treatment programs, costing $200 million, boosted income by 8%. Health economics quantifies these benefits, showing $1 in health yields $3 in GDP growth. AI-driven disease management, adopted in 2025, saved $50 million. These insights guide policies to reduce poverty, as we'll explore with capital accumulation. Poor health reduces savings, impacting physical capital. In Canada, high health costs, affecting 10% of households, cuts savings by 12%, per 2024 Statistics Canada. This limits capital investment, slowing growth. Health and capital are complementary. Healthier workers use capital more effectively. A 2024 program in Alberta improved health, boosting capital productivity by 8%. Recent 2025 investments, costing $500 million, raised GDP by 1%. Health economics prioritizes these, as we'll explore with efficiency. Poor health impacts aggregate efficiency. In Canada's production function, high disease burdens reduce technology adoption by 10%, per 2023 CE. Health improvements, like 2024 vaccination programs, boosted efficiency by 5%, saving $100 million. Recent 2025 AI diagnostics enhanced efficiency, saving $50 million. Health economics shows $1 in health yields $2 in GDP growth. These insights guide policies to improve efficiency, as we'll explore with institutions. Poor health influences institutional quality in Canada. High disease burdens, like diabetes, weaken health systems, reducing governance scores by 10%, per 2023 CE. Health improvements, like 2024 pharmacare programs, boosted governance by 5%. Health economics shows $1 in health improves institutional quality, raising GDP by 1%. Recent 2025 programs, costing $200 million, enhanced health systems. These insights guide policies, as we'll explore with social cohesion. Health inequality reduces social cohesion in Canada, increasing unrest risk. In 2024, 20% of low-income Canadians lacked health access, fueling tensions, per Statistics Canada. A 2023 study linked disparities to 15% higher protest rates. This destabilizes economies, reducing growth. Recent 2025 clinic expansions, costing $100 million, reduced unrest by 5%. Health economics shows $1 in equity yields $2 in stability gains. These insights guide policies to enhance cohesion, as we'll explore with education. Health affects education in Canada through multiple mechanisms. Poor health reduces school attendance. 20% of low-income children miss school due to illness. Per 2024 CIHI, malnutrition, affecting 10% of children, lowers cognitive scores by 12%. Per 2023 Statistics Canada, recent 2025 nutrition programs, costing $100 million, increased attendance by 7%. Health economics shows $1 in health yields $5 in educational benefits. These insights guide integrated policies, as we'll explore with evidence. Evidence on health's impact on education in Canada is mixed. Non-experimental studies, using correlations, show ambiguous results due to unobservables like parental education. A 2023 study found 20% of health education links were biased. Per CIHI, RCTs offer clearer evidence. A 2024 RCT in Manitoba showed nutrition programs raised attendance by 8%. Recent 2025 AI-driven studies improved precision, confirming causality. Health economics shows $1 in health yields $4 in educational gains, guiding $200 million in 2024 programs, as we'll explore with a specific example. The 2024 Manitoba Nutrition Program, an RCT, tested health's impact on education. Food insecurity, affecting 10% of children, causes malnutrition, reducing attendance. The program, costing $50 million, provided free meals, reducing food insecurity by 5% and boosting attendance by 8%. Per CIHI, health economics quantifies these benefits. $1 in nutrition yields $6 in economic gains. A 2025 follow-up expanded the program, saving $20 million in health costs. These findings guide scalable interventions, as we'll explore with program details. The Manitoba Nutrition Program, launched in 2024, involved 50 schools randomized into 3 groups. One received meals from 2024, another from 2025, and a control group. This RCT design isolated health's impact. The program, run by a local NGO, cost $50 million and reduced food insecurity by 5%. Health economics shows $1 in nutrition yields $5 in educational benefits. A 2025 scale-up, costing $100 million, boosted GDP by 1%. These findings guide national policies, as we'll explore with the results. The Manitoba Nutrition Program surveyed children biannually, showing a 5% reduction in food insecurity and an 8% increase in school attendance. Per 2024 CIHI, however, cognitive test scores showed no significant gains, suggesting long-term impacts need further study. Health economics quantifies these benefits. $1 in nutrition yields $5 in economic gains. A 2025 scale-up, costing $100 million, reduced health costs by 3%. These results guide policies to improve education, as we'll explore with labor outcomes. Better health improves labor outcomes in Canada by increasing wages and productivity. A 2023 study found diabetes treatment raised wages by 10% in Ontario. Per CIHI, chronic diseases, affecting 20% of workers, cut labor supply by 15%, costing $10 billion annually. Recent 2025 health programs, costing $200 million, boosted productivity by 8%. Health economics shows $1 in health yields $3 in income gains. AI-driven labor models, adopted in 2025, guide $500 million in workplace health programs, as we'll explore with evidence. Evidence shows healthier Canadian workers earn more. A 2023 study found a 10% wage increase for those with better health. Per Statistics Canada, nutrition improvements, like 2024 school programs, increased labor participation by 8% in Manitoba. Recent 2025 interventions, costing $100 million, boosted GDP by 1%. Health economics shows $1 in health yields $4 in economic gains, guiding policies to enhance productivity, as we'll explore with health measures. Health measures like morbidities, disease presence, activities of daily living, ADLs, e.g., mobility, and health limitations predict labor outcomes in Canada. A 2023 study found high morbidity reduced wages by 12%, per se. ADLs, like difficulty walking, cut participation by 10%. Recent 2025 disability programs, costing $100 million, increased participation by 7%. Health economics shows $1 in health yields $3 in economic gains, guiding policies to address barriers, as we'll explore with further evidence. ADLs predict labor participation in Ontario, where mobility issues reduced work by 10%, per 2023 CIHI. A 2024 RCT in Quebec provided nutrition supplements, increasing productivity by 8%. These experiments confirm health's impact, guiding $100 million in 2025 programs. Health economics shows $1 in health yields $3 in economic gains. These findings ensure policies target specific barriers, as we'll explore with the nutrition's role. Better nutrition improves health and labor outcomes in Canada. A 2024 study found nutrition programs in Ontario raised productivity by 10%, per se. Low nutrition cuts output by 12%, costing $5 billion annually. Recent 2025 initiatives, costing $200 million, reduced malnutrition by 7%. Health economics shows $1 in nutrition yields $5 in economic gains, guiding $500 million in 2024 programs. These insights enhance productivity, as we'll explore with general comments. Health investments in Canada disproportionately benefit low-income groups, enhancing income generation. Preventive care, like vaccinations, yields high returns. $1 saves $10 in costs, per 2024 CIHI. Focusing on preventable diseases, like diabetes, is critical, yet 20% of budgets go to high-tech treatments. Public health infrastructure, like $500 million in 2025 clinic expansions, boosts productivity by 8%. Health economics shows $1 in health yields $3 in GDP growth. Recent AI-driven analyses, adopted in 2025, optimize investments, ensuring equitable economic development. Thank you for your attention.